all of you in this place, our 18th midterm conference of Patna Muslim Society. Thank you so much for everyone for taking pain to reach from Patna to Gaya, and congratulations and thanks to the LOC for nice venue and nicely organize all the things. We are going to start first session, the free PG free paper in oculoplasty. May I request Dr. S.K. Rungta sir to chair the session, and I think Dr. Javed, Dr. Nilesh is here to for the panelists, and Dr. Vivek Singh, and Dr. Ajay is not here, Dr. Gautam is not here. And today's judge of this session is Dr. Santosh Sanawar sir, and Dr. S.K. Rungta sir, and Dr. Sahid Alam. The first presenter is Dr. Shahrukh Khan. Sir, please can you sit, take the, Santosh sir, please take the chair, sir. And also our secretary Satyajit sir is here. Sir, may I request to chair the session, sir, the session. जी सर, आप इधर आ जाइए सर, आप भी आ जाइए सर. डॉक्टर नीलेश प्लीज.
So the first presentation will be by Dr. Shahrukh Khan, and he will be presenting a case of blepharochalasis, a case report. So please make sure that it is below 6 minutes so that you don't get any negative marks.
Thank you, sir. Good morning, everyone. Myself, Dr. Shahrukh Khan, second year junior resident, Anugrah Narayana Magadbhai Medical College, Gaya. My topic is blepharochalasis. A 11-year-old boy from a nearby village came to OPD presenting with wrinkling of the skin of the upper eyelid. The parents said that when the patient was 7-year-old, he took bath in a river and shortly thereafter developed painless swelling of upper eyelids. After the swellings of the lid subside, the patient father noticed wrinkling of the skin of the upper eyelids. At the age 9, the patient again developed mild swelling on his eyelids 3 times in a single year that gradually subsided within 1 to 2 days each time. But the laxity and wrinkling of the skin increased and has since persisted. During each episode, swelling lasted for 1 to 2 days. Local examination revealed lax and wrinkled skin of both upper eyelids without erythema. The redundant skin folds extended over the margin of the eyelids. There was no ptosis or laxity of the skin elsewhere on the body. Rest ophthalmic examination was normal, visual acuity was normal, extraocular movement, anterior segment and fundus examination was within normal range. There is no significant systemic examination finding was there. There was no other associated illness and child did not have an atopic history. No similar lesion were present on the body and there was no history of angioedema at any other site. There was no family history of angioedema. His hematological profile, urine analysis, kidney function, liver function, thyroid function were within normal limits. Parents denied consent for biopsy. The diagnosis of blepharochalasis was made on the basis of clinical presentation. Now here is a brief introduction for about blepharochalasis. Blepharochalasis is an atypical pathologic condition that appears to be a result of inflammation. It is most often found in young patients during puberty. The clinical findings include attenuation, atrophy and drooping of the eyelids. This occurs after recurrent swelling of the eyelids. Swelling episodes are painless. Repeated swellings causes a stretching of the skin that frequently result in permanent skin excess and dropping lids. This may lead significant visual impairment even in younger and active patients. The exact etiology of blepharochalasis is not known. The condition is commonly reported during puberty. There have been multiple systemic association described. A link to Usher syndrome, a rare condition characterized by attack of upper eyelids and lips edema with or without euthyroid goiter, has been suggested. Other theories suggest hormonal changes, especially during puberty. Upper respiratory tract infection and allergies may also play a role in disease progress. Now first stage is edema stage, also called an active intumescent phase. The first stage is intermittent non-pitting edematous painless swelling of the upper lids, which is usually misinterpreted until the permanent changes occur. The lid swelling is painless and transient. It lasts for 1 to 2 days with mild redness of the skin resembling angioedema may be present. Second stage is atonic ptosis stage. The skin becomes discolored, reddish brown, heavily venuled and flabby. The loose skin hang over the lashes. The power to lift the eyelids is decreased. Third stage is ptosis adiposa. In the third stage, with further progression, there is relaxation of the tissues of the orbital septums. The orbital fat drops into the relaxed eyelids, way down the skin in full heavy transverse folds. The palpebral fissure narrows and interferes with vision. The lacrimal gland may be pulled below the orbital margin, giving the face a tired appearance. Pathophysiology, the etiology is obscure and the ultimate mechanism causing the disease have not been elucidated. The acute inflammatory episode have been compared to localized angioedema, in which an unknown trigger lead to a vascular impairment causing liquid extravasation and swelling attack. Histopathology of lesion skin shows mild dermal lymphocytic infiltrate in early stages and decreased fragmented elastic fibers in later stage. Loss of elastic fiber is the most consistent finding in histopathology. Deposition of IgA's residual elastic fibers can be present, implying that an autoimmune mechanism may be involved. Why this inflammation or idiopathic angioedema is confined to the eyelids also remain unknown. Differential diagnoses are dermatochalasis, which refers to lax or redundant upper eyelid skin commonly associated with hanging, may be confused with blepharochalasis. However, the dermatochalasis is not associated with characteristic finding of blepharochalasis. Other diagnoses to consider would be thyroid eye disease, floppy eyelid syndrome, orbital cellitis, idiopathic orbital inflammation, hereditary angioedema, dacroadenitis, lacrimal gland tumors, and localized cutis laxa. Management, there is no established medical therapy for blepharochalasis. Management is surgical intervention. Surgical intervention are aimed at correcting the complications of blepharochalasis, most commonly ptosis and eyelid skin laxity. Surgical correction should be delayed until late in the disease course when attacks have become infrequent. Disease quiescence for 6 to 12 months is recommended for prior disease. Thank you, sir. Unfortunately, the same inflammatory process which results in the blepharochalasis may cause ptosis and eyelid skin laxity to recur after surgical repair. Patients should therefore be counseled appropriately. Complications, it is a non-sight threatening disease, and its complications affect mainly the periocular anatomy. Ptosis, herniation of the orbital lobe of the lacrimal gland, prominent eyelid vascularity, orbital fat pad atrophy, and all complications which may arise from this condition. So the question is, why do we need to know about blepharochalasis? Although blepharochalasis is a rare disease with unknown etiology and no universally recognized curable treatment at present, however, it has no severe consequences for the patient's sight. It is important to know the disease to avoid a delay in making the diagnosis, which can result in patient anxiety. Once the diagnosis is made, it is important to inform the patients about the condition, the possible triggers, and some local measures that can be tried during the swelling episodes, such as application of local cold. Thank you.
Thank you. But अगर कोई भी exceed करते हैं तो marks will be deducted. Requested to everyone, please stick to your time.
How many cases you see?
Sir, I have seen a single case. Second case was little.
Though it's a rare condition, yeah.
Ji, sir.
But even then you will get it.
So second case was 55-year-old male. We were sure, but age was on the higher side, so
Yeah, the main thing is cosmesis.
जी.
And sometimes the drooping varies with the time. That is also important. So we would like to hear from Dr. Honawar sir. Anything?
I think he's described it very well, but the management aspect was lacking in your case in the sense that, well, you conservatively you managed and observed, but surgical intervention you didn't bring up, possibly it was not done, right? And the pictures, I mean, if you show pictures, that will be more illustrative. Otherwise, yeah, of course, it's a innocuous, benign condition, generally does not respond to medical treatment, although non-specific and non-steroidal anti-inflammatory medications, steroids have been used, azathioprine has been used to break the attack or decrease the frequency between the attacks. And quiescence of more than 6 months or a year is an indication for surgery or any functional issue where ptosis covers more than half of the pupillary aperture and patient has functional problems, then surgery can be considered at an early stage.
Thank you, sir. Next presentation.
Just 1 second, sir. So, yeah, nice case. Can you just tell us what is that appearance of a skin called?
That's a cigarette paper.
Yeah, cigarette paper skin. And how will you differentiate it from angioedema? What all tests will you do to know whether it's angioedema or not, hereditary angioedema? And
Sir, hereditary angioedema में family history
no tests.
test. Sir, skin laxity test जिसमें skin को क्या कहते हैं stretch करके वो वापस
And
recoil.
how do you differentiate from it from dermatochalasis?
Dermatochalasis, sir, first of all, sir, age group.
Okay.
Second, उसमें recurrent जो swelling episodes हैं वो नहीं होंगे और वो सर एक senile change है और इसमें early age से recurrent swelling.
Okay, thank you.
Thank you, sir.
Okay. Next presentation is by Dr. Nabya Nikita, Management of Grade 4 Senile Ectropion with Recurrent Conjunctivitis.
So at 5 minutes, I'll give the warning bell. So,
Good morning, respected faculty members, dear colleagues. So today my topic for today is management of grade 4 senile ectropion with recurrent conjunctivitis. There is no financial interest. So a patient, 70-year-old male patient came in my OPD with complaint of outer turning of the lower lid and watering of both eyes since 2 years, along with 2 to 3 episodes of redness and mucopurulent discharge that was present since 2 years, which worsened over 6 months. He denied any history of trauma, skin cancer, ocular allergy, surgery, use of any topical medications or any significant sun exposure. There was no significant past medical history, allergy or family history. There was also no social history. The review of system was also non-contributory. So coming to the ocular examination, the visual acuity of the patient under OD was 20/60 with pinhole 20/40 and under OU it was 20/80 with pinhole 20/60. Pupil was CRR, IOP were within normal limits. Under eyelid examination, we examined the patient and both eyelids saw poor snapback test, poor apposition of the globe, positive distraction test, 2 mm inferior scleral show was also present. Hyperemic conjunctiva with yellow crest was also present in both the conjunctiva. Cornea was clear, lens showed grade 2 nuclear sclerosis, fundus and ocular motility was also within normal limits. So my provisional diagnosis made was right eye grade 3 and left eye grade 4 involutional ectropion with bacterial conjunctivitis. So the patient was primarily treated for conjunctivitis on topical antibiotic eye drop plus ointment, lubricating eye drop and ointment for 1 week, and then was planned for surgical correction of first left eye ectropion after resolution of ocular symptoms. He was then asked to come next week for follow-up with blood investigations. So the next week the symptoms are resolved as we can see in the picture and was planned for surgical correction of the ectropion, and the blood investigations were also within normal range. The patient then underwent left eye ectropion repair with a lateral tarsal strip procedure. So here we can see the figure that shows the post-op appearance Pre-op and the post-op appearance 1 week, that showing result which shows continued stability of the lower eyelid. Coming to the discussion, so ectropion is one of the most commonly encountered eyelid disorders seen in ophthalmology. It means outward turning of the eyelid margin. It's graded as 1 punctal eversion, 2 eversion of sharp posterior lid margin, 3 palpable conjunctival exposure, and 4th exposure of the fornix. It is classified into several categories including involutional, cicatricial, paralytic, mechanical, and congenital. The most common being involutional ectropion. So here the patient experiences symptoms of ocular irritation including redness, discharge, papillary reaction, and corneal epitheliopathy. Exposure of the palpebral conjunctiva causes conjunctival inflammation and poor lid protraction resulting in inferior corneal exposure. So the most common anatomic changes leads to horizontal lid laxity, lamellar dissociation, and retractor disinsertion. So coming to the management, the generalized ectropion is managed without excess skin condition. Pentagon excision is performed. With excess skin laxity, Szymanowski procedure, lateral canthal laxity, lateral tarsal strip procedure is performed. Under medial ectropion, if there is no horizontal lid laxity, medial conjunctivoplasty, with horizontal lid laxity, lazy T procedure, and under medial canthal laxity if it's present, medial canthal laxity resection is done. So cicatricial ectropion, it is usually associated with shortening of lamella that is caused due to burns, actinic damage, autoimmune disease, or any chronic inflammation. Mechanical ectropion, it is a situation that occurs due to the mass on the lower lid which pulls down or away from the globe, and its treatment is based on removing of the mass. Paralytic ectropion refers to retraction of the upper eyelid, lag of thalamus, and corneal exposure, and congenital being rare. Thank you so much.
Sir, any comments or question from our judges?
You really didn't mention how was this particular patient treated?
Sorry, sir.
Managed, surgical management.
It was managed by lateral tarsal strip procedure.
Okay.
The
But when the ectropion is so global in the sense that it is not just the lateral laxity, it's the entire lid is turned out. It's like a global ectropion where there is medial canthal laxity as well as lateral canthal laxity. Do you think lateral tarsal strip would be a good procedure, or are there any alternatives?
Sir, if medial canthal laxity is present, so we can also go ahead with medial conjunctivoplasty, medial canthal resection. But here we have went with lateral tarsal strip procedure being the most common surgery which we perform.
All right.
How do you manage dry eye situation in such cases?
So we give lubricating eye drop and lubricating ointment which is given BD for 1 week or and then we call the patient, and also before managing we examine the dryness, that is with Schirmer's test.
Okay, what is the pathophysiologic difference between a senile entropion and senile ectropion?
So in senile ectropion, the patient, because of the gravitational effect and because of the constant rubbing, the outer turning of the eyelid margin is seen. And in case of involutional entropion, because due to the aging process,
Both are aging process. So what is the pathophysiological difference? That one goes to entropion and the other one into ectropion.
in case of senile entropion, there is shortening of the anterior lamella. That is why we can see senile entropion.
Okay.
Okay. Thank you, Dr. Nabya. May I request Dr. M. Muthukrishnan to present on upper lid management, mass managed with excision and lid reconstruction, ocular aesthetic matters.
Good morning everyone, I am Dr. Mohan Raj. I am going to present upper lid malignant mass managed with excision and lid reconstruction, ocular aesthetics matter. I have no financial conflicts of interest to disclose. A 46-year-old female presented with the chief complaints of mass over the left upper eyelid for last 1.5 years, which was gradually increased in size associated with mucopollulant discharge intermittently. She underwent homeopathic management for the mass without improvement, not associated with pain, change in color, loss of eyelashes, irregular lid margin, increase in size on bending forward, no history of recurrent eyelid swelling, radiation exposure, swelling from any other part of the face. Past history, she was known case of hypertension and diabetes, on treatment for 1 year, no history of any previous eyelid surgery, trauma, any other systemic illness. Local examination, inspection on ventral surface of the mass shows approximately 2 cross 2 centimeter globular shaped mass present over the left upper lid, involving more than half of the lid, with minimal mucopollulant and bloody discharge. Color is similar to surrounding skin. Dorsal surface, it shows irregular conjunctival surface, yellowish multiple nodular mass with vascularization with the central pigmentation. Palpation, which the mass is hard in consistency, fixed to the underlying structure. Skin was not pinchable. There was no regional lymph node enlargement. Auscultation, no bruit. Ocular examination in the left eye shows best corrected visual acuity was 6/36. In the left eye lid and adnexus shows mass over the left upper lid with severe ptosis, so rho plus negative, vertical palpebral fissure height 4 mm, minimal mucopollulant discharge plus. Conjunctival shows vascularized growth in the palpebral conjunctiva normal. Rest of the anterior and posterior segment of the eye was within normal limit except both eye nucleus sclerosis grade 2. Routine blood investigation done. Blood sugar was within normal limit, so within the control. Incisional biopsy sent, which shows vacuolated cytoplasm with vegetoid spread of the tumor identified. It shows it's suggestive of sebaceous gland carcinoma of the left upper eyelid. Diagnosis: left upper lid sebaceous gland carcinoma with a severe mechanical ptosis, both eye NS2 cataract with hypertension and diabetes mellitus. Management: left eye upper lid mass, wide local excision with the frozen section with the lid closure by cutler bed method. We initially did 4 mm wide mass excision, sent for histopathological examination frozen section. It shows tumor free margin. Then we proceeded to the stage 1 cutler bed surgery. Excisional biopsy result came as 2.6 cross 2.4 cross 1.3 centimeter, relatively circumscribed gray white to yellow mass. It shows foamy and vacuolated cytoplasm. All margins are free of tumor. Feature suggestive of sebaceous gland carcinoma, moderately differentiated. This first image shows POD 9 of stage 1 cutler beard. It shows wound healthy. After 1.5 months, we did stage 2 cutler beard surgery. POD 9, the lid closure is adequate. This is a 6-month follow-up. No entropia, ectropia noted. No recurrence noted. Discussion: basal cell carcinoma is the most common. Basal cell carcinoma, the commonest eyelid malignancy in the worldwide. Sebaceous gland carcinoma more frequently seen in the Asian and Asian Indian population. Second worst prognosis among eyelid malignancy. Overall mortality rate was 5 to 10% in the sebaceous gland. Types: nodular and spreading variety. There is various method for lid closure of the lid defect. It based on the surgical method based on whether which was only involved in the anterior lamellar defect or full thickness margin involvement. In my case, it is large involvement involved in the upper lid, so we choose cutler bed method. Indication of eyelid reconstruction: not only the surgical after surgical excision of the tumor, congenital condition like a coloboma, acute condition, trauma, irradiation, burns, following previous complicated surgery, we should do eyelid reconstruction procedures. Take home message: all cases of chronic blepharitis, recurrent chalazion, suspect eyelid malignancy. Eyes are the focal point for facial cosmesis. Acceptable cosmesis in the reconstruction become a major request. Avoid cutler bed surgery in monocular or infants because risk of amblyopia. Thank you.
Thank you, Dr. Mithu Krishnan. Sir, any comments or questions? Santosh?
What was your follow-up period?
Sir, 6 months we followed, sir. After 1 year patient last follow-up, we called and asked to come, they didn't come, sir, but they don't have any complaints like that.
But I think you must keep the patient under follow-up still.
Yes, sir.
What complication, you did not get any complication out of surgery in this case?
Complication, yes.
No, nothing.
I think very well managed, protocol-based management. Couple of things that are missing is one is map biopsy. Any lesion which is as large as this, you should possibly do map biopsy to rule out pagetoid invasion. And the second is regional lymph node evaluation. You know, PET
Min-
CT scan, head and neck.
So, clinical examination.
Clinical is fine, but any tumor which is more than, if facilities are available, which I'm sure AIMS has, so head and neck PET scan for any tumor which is more than 10 millimeter in dimension, which is a higher risk for regional lymph node metastasis, baseline at least.
So, as sir said, hello. So, like a map biopsy was indicated because you mentioned that there was pagetoid spread, right?
Incisional
So,
biopsy,
map biopsy was indicated. And, with such a large tumor with almost like, you said 2 centimeter was the dimension, and then additional 4 mm on both sides, almost 28 mm. So, almost whole of the lid needs to be sacrificed. So, suppose if we don't consider cutler beard in this case, so what other like are the management options for reconstruction?
reverse Huggies, mustard.
Apart from lid sharing, any other thing that that can be done for like where you need to sacrifice almost whole of the upper lid? So a forehead flap lined with mucous membrane graft can be tried. Okay.
Thank you, sir. Next presentation, presenter is Dr. Abhishek Ranjan. He is going to present primary neuroendocrine tumor of the eyelid, a rare case.
Good morning, everyone. Myself, Dr. Abhishek Ranjan, first year PG from RIO IGMS Patna. I'm going to present on the topic primary neuroendocrine carcinoma of lower lid, clinico-pathological case report. There is no financial disclosure. Ethical clearance has been taken from the department. Written informed consent from the patient has been taken. Neuroendocrine neoplasm are a rare but challenging oncological entity. They originate from neuroendocrine cell, which are located in different organs such as lungs, GIT, and the skin. Primary neuroendocrine carcinoma of extrapulmonary site are extremely rare, but are very important to diagnose because they are very aggressive. We present a clinical histopathological correlation of a patient with a primary moderately differentiated neuroendocrine carcinoma of right lower eyelid. Here is a 72-year-old woman presented with a mass in the right lower eyelid that was first noticed as a pea-sized nodule 6 months earlier and had rapidly grown into 4 into 3 centimeter mass since then. The lesion was not associated with pain or loss of vision, although the field of vision was restricted due to hindrance from the mass. There was history of an on and off blood-tinged serous discharge from the lesion. There was no history of trauma in the past. There was no history of cough, hemoptysis, raised body temperature, weight loss, night sweats. There was no history of altered bowel habits or melena. There was no history of diabetes, hypertension, tuberculosis, or any decreased immune states. There was no significant drug or medication history. Patient general physical examination was within normal limit. Systemic examination was within normal limit. Local examination, we found a reddish, russet-shaped exophytic mass seen protruding from anterolateral aspect of right lower eyelid, measuring approx 4 into 3 into 3 centimeter. The external surface of skin is congested with visible distended subcutaneous vessels. Superior surface is ulcerated with serosanguous discharge mixed with blood seen oozing from the surface. There was associated loss of eyelashes and distorted eyelid anatomy. On palpation, the measurement of the mass was confirmed as 4 into 3 into 3 centimeter, non-tender, soft to firm in consistency, with ulcerated superior surface, non-mobile, fixed to underlying skin, not adhered to bone. The local temperature was not elevated. Auscultation revealed no additional information. Ocular examination of the both eye was more or less within normal limit. Investigation, routine blood investigation, chest X-ray, ECG, USG, whole abdomen was within normal limit. We performed CECT brain and orbit. Here we can see the tumor, the growth tumor we can see here. There was no bony involvement. The tumor was extending to anterior orbit, but the intraconal compartment as well as the optic nerve was free of tumor. There was slight budding from the tumor of lateral rectus muscle. Based on clinical radiological analysis, following provisional diagnoses were considered: squamous cell carcinoma, basal cell carcinoma, neuroendocrine carcinoma, sebaceous cell carcinoma, metastatic carcinoma. To confirm the diagnosis, patient was immediately planned for incisional biopsy and histopathological examination. We see the incisional biopsy was done. This is post-op day 1, 3, and 7 picture. In histopath, in low magnification, we can see the epithelium is relatively free of tumor. Tumor is mostly seen in the subepithelial compartment. In higher magnification, there is hypercellularity seen. In high power magnification, we can see the tumor is arranged in organoid and rosetoid pattern, round to oval cell with high NC ratio. This stippled chromatin was seen, high mitosis was seen, nuclear molding was seen, and area of cellular debris was found, which was suggestive of a high-grade tumor. These features on HP raised the possibility of aggressive neuroendocrine carcinoma. So full panel IHC was done. And we found out the synaptophysin was positive, chromogranin was patchy positive, and NSE non-specific stress was also positive. Full panel IC confirmed the diagnosis of neuroendocrine carcinoma. Current status, patient is under close monitoring and is receiving radiotherapy at State Cancer Institute, Patna. CMRI is planned to look for progression, intraocular extension, and surgery is to be planned accordingly at the earliest. Discussion. Neuroendocrine tumors are malignant growth that arise from neuroendocrine cells. They are most commonly occur in GIT, lungs, and pancreas, but may also develop in many other organs, including breast, prostate, thymus, and skin. Neuroendocrine cells have the capability to produce hormones such as serotonin, which can result in symptoms such as flushing and diarrhea, as well as other proteins like chromogranin A, which serves as biomarker for neuroendocrine tumors. Neuroendocrine tissues also tend to express somatostatin receptors on their cell surface. Therefore, somatostatin analogs can be used for diagnostic imaging and treatment. Grading, there are two main features of grade. The Ki67 index, which measures the percentage of cancer cells that stain positive for Ki67, a marker of cell proliferation, and the mitotic rate, which documents the number of mitoses per 10 high power microscopic fields. According to European Neuroendocrine Tumor Society, well differentiated low mitosis tumor grade 1 and grade 2 are referred to as neuroendocrine tumors, whereas poorly differentiated high mitosis neoplasms such as muscle cell carcinoma of the eyelid are classified as high grade neuroendocrine carcinomas. Treatment, surgical excision, radiation therapy, chemotherapy, and immunotherapy have all been used to treat neuroendocrine carcinoma. For surgical excision, wide excision with 1 to 2 mm margin is recommended. Additionally, given the radiosensitivity of this tumor, adjuvant radiotherapy may be warranted. Chemotherapy is efficacious in treating neuroendocrine carcinoma as first-line treatment for disseminated or metastatic disease, rather than as a local or adjuvant treatment. Immune-based therapy have demonstrated promising results in clinical trial. Pravolizumab, nivolizumab, avelumab help to restore T-cell response against tumor cells. Conclusion and key takeaways. Considering the aggressive nature and metastatic potential, provisional diagnosis of neuroendocrine tumors should be considered in all cases of rapidly growing tumor of ocular adnexia. Primary neuroendocrine carcinoma of eyelid is extremely rare, but the tumor has high malignant and readily spreads. Thus, combined therapy including surgery, radiotherapy, and chemotherapy is needed for complete management of neuroendocrine carcinoma. These are my references. Thank you.
Thank you, Dr. Abhishek. Any comments and questions for our
I
judges?
think it's a very well managed case so far. I mean, basically surgery is the treatment of choice. You have to surgically clear the tumor, otherwise there is a high chance of local tumor recurrence. Chemo is only supportive. Pembrolizumab is very expensive, so it is, although it is available in India, it is difficult to use in many patients. So what probably you're trying to do is reduce the tumor bulk by doing radiation and then plan for surgery,
Yes.
right? So I think that's a good approach.
Was a PET CT done to look for any primary?
PET CT was not done, sir.
No, a PET CT should have been done because there are chances that it could be a secondary tumor of the eyelid from primary from somewhere else like colon or rectum where a neuroendocrine tumor is more common.
So for lungs, other investigation like X-ray,
Yeah,
and we
so
planned for
a PET CT should be
PET
done.
CT.
Yeah, to look for like whether it's metastatic or not.
Dr. Abhishek, how many slides were there in your presentation? 33. You have got 6 minutes time. You cannot cover more than 5 slides in a minute. So before presenting, you calculate, because there are all minus points in competitive presentation. This is just by the way.
Thank you, Dr. Abhishek. Next presentation is by Dr. Sumedha Prasar. Clinicopathological analysis and the future of lead tumors. Retrospective study.
Good morning, everyone. This is Dr. Sumedha Parashar, and my today's presentation is on clinicopathological analysis and demographic features of eyelid tumors, a retrospective study. There is no financial interest. Objective. The study aimed to evaluate the epidemiological and clinicopathological spectrum of eyelid tumors among patients presenting to RIO IGMS Patna. A total of 24 patients of lid tumor were included in this study. Tumor type and size, primary origin and location of tumor, clinical staging, radiological findings, histopathological type, and treatment outcomes were assessed. So material and method. This was a retrospective study conducted at RIO between October 23 to March 24, a period of 6 months. A total of 24 patients presenting with lid tumors of variable size, shape, and clinical features were included in this study. Patients presenting with these symptoms were assessed with detailed history, examination, and parameters like inspection, palpation, percussion, and auscultation, along with measurement of presenting lesions. Slit lump examination were done in all patients for periocular and anterior segment examination, supplemented with indirect ophthalmoscope examination posterior segment if possible. Further, the patients were advised for an imaging test like CT or MRI to know the extent, nature and the underlying bony condition of the lesion. After proper workup, patients were planned for surgical excision along with lid reconstruction technique if required. So the results were overall females over 50 years of age were most commonly involved, and majority of the cases were malignant lesions. All cases were unilateral involving either upper or lower lid. All cases were managed by primary surgical excision. 16 patients underwent lid reconstruction. 5 out of 24 cases were operated without radiological intervention. Confirmed diagnosis of all cases were made histologically. 21 patients recovered completely, with 3 patients had recurrence. So demographic characteristic, gender involved was male, there were 9 males and 15 females, and the age group was from 0 to 25, 7, 26 to 52 patients were there, and 51 to 75, 15 patients were there. 7 patients from urban locality and 17 from rural, and the education status of the patient were 10 patients were illiterate and 14 were literate. Then clinicopathological characteristic, 9 tumors were benign and 15 malignant. 24 cases, all cases were unilateral. 14 cases were involving the upper lid and 10 cases involving the lower lid. And lymph node was present, preauricular lymph node was present in 1 case, whereas in 23 cases there was no lymph node palpable. And no patient were presented with metastasis, distant metastasis. So incidence of different benign eyelid tumors, there were a total of 9 cases, out of which 3 cases were of neurofibroma, and 3 were of vascular lesion, and 2 were of squamous papilloma. Here is the pie chart showing the same. Another was for the malignant eyelid tumor incidence. There was squamous cell carcinoma, sebaceous gland carcinoma, and basal cell carcinoma incidence. The pie chart showing the incidence of the same. So management, all cases were managed by surgical excision plus minus lid reconstruction. Small benign tumors were simply excised with histopath examination as they didn't create any lid defect. Large benign mass like neurofibroma underwent debulking. Lid reconstruction of malignant masses were done after frozen section confirmation only. Those malignancies where frozen section couldn't be done were left as such for secondary repair post histopath examination confirmation. So treatment procedures, simple excision plus histopath examination were done in 5 patients, and excision plus primary lid construction. The primary lid construction involving cutler bead surgery was done in 6 patients. Tangial rotation flap was done in 3, and debulking surgery was done in 3 patients. Primary repair plus lateral canthotomy was done in 2 patients. Excision plus delayed reconstruction, that is laissez-faire technique, was adopted in 5 patients. Here is the image of a patient showing neurofibroma, plexiform neurofibroma, and it was managed surgically by debulking, and the post-op, pre-op and post-op image of the patient along with the radiology. This is a 70-year-old male with a right upper eyelid sebaceous gland carcinoma with histopathological report of a moderately differentiated sebaceous gland carcinoma, showing lobules of malignant cells with sebaceous differentiation. A clinical photograph of a pigmented basal cell carcinoma on the left lower eyelid, micrograph of the basal cell carcinoma showing nest of the atypical cells, leaden basal cells with peripheral palisading and mitotic figures, sebaceous gland carcinoma of the upper eyelid involving more than 50% of the eyelid, managed by Cutler beard surgery. Here's the pre-op and post-op picture of the same. Here is the tangential rotation flap done for the upper eyelid tumor, which was involving approximately half of the lid. 2 patients that had lid defect less than 50%, and due to skin laxity, primary closure was done with lateral canthotomy. 3 cases were managed by laissez-faire technique, where the tumor was excised and the margin was left as such, and we were waiting for because the frozen section was not available, we were waiting for the histopathological examination report, and post confirmation we will do the secondary repair. Here the lymph node was pre-auricular lymph node was also positive as shown in the picture. Here the pre-auricular lymph node was also excised and sent for histopathological examination, and this is the post-op picture. So conclusion, on the basis of these cases, we were able to conclude that eyelid tumors are quite common presenting in oculoplastic clinics. Malignant tumors like squamous and sebaceous cell carcinomas can also present. Thus, early diagnosis and management of these cases is of utmost importance. Most of the patients came for treatment in late stages due to numerous factors like financial reason, ignorance, lack of awareness, and dependence on homeopathic medications. Thus, one step to halt the progression and effective treatment of tumor is to create awareness among general population. Metastasis to various sites of body can contribute to mortality and morbidity among these patients. Various techniques are performed to excise eyelid tumor, followed by histopathic examination to detect the tumor-free margin and subsequent need for radio or chemotherapy. Thank you.
Thank you, Dr. Thank you, Dr. Sunada. Any comments, question?
Very good collection. But how many cases were there altogether?
Sir, total 24.
Total?
24.
24 cases. And this is a good thing. I think very few ophthalmologists are doing such type of, they are taking such cases for treatment. So if you really take interest, this is also a social service also. Thank you.
I have just 2 questions. So you said like in the age group of 0 to 25, there were around I think 7 patients. So
Yes,
were all of them were benign?
Yes, sir, benign.
All benign.
Yes, sir.
So do you remember like what all tumors like?
Sir, 2 were squamous papilloma, and 3 patients were vascular tumor it was, and the rest of the 2 patients were, sorry.
Okay. What was the incidence of systemic spread?
No, sir, there was no incidence of systemic spread in all of the cases. There was no distant metastasis.
Very nice series. Large series in 6 months, you know, it's a very high incidence that you have. What about the 3 cases that recurred? What do you think was the reason for recurrence, and what was done for them?
Sir, one of the case was of sebaceous gland carcinoma. First, it was involving the lower eyelid. So, it was not involving any of the upper eyelid and all. So, we operated on the lower eyelid. Then, the patient, after 2 months, she came back with the upper eyelid tumor.
Okay. So, that means it was multicentric?
Yes, sir.
Okay. Right. All right.
Thank you, Dr.
Just wanted an opinion on this. So squamous cell carcinoma seemed much more than basal cell carcinoma. So in the case series,
that is absolutely right. In India, it is sebaceous first,
Sebaceous
followed by
first.
squamous, and the last is basal.
Basal. Okay.
At this moment, sir, I will appreciate Dr. Santosh Sanova. Everybody is there in the audience, everybody is listening, but he observed that 3 cases were recurrent cases. I could not notice. So there is difference.
Thank you, Dr. Sunada.
Thank you, sir.
Next presenter is Dr. Amit Kumar, management of ocular and dental injury and क्या हुआ? अभी ट्रांसफर कर लो, डॉक्टर उत्कर्ष आ जाएंगे. उत्कर्ष का है सर. डॉक्टर उत्कर्ष. ठीक कर लो.
A very good morning to all respected chairpersons, judges, seniors, and all present over here. I present to you a case of unilateral Duane retraction syndrome with contralateral pseudoproptosis and bilateral ptosis. No financial interests. The case is a 22-year-old female presenting with protrusion of right eye for 10 years. History of present illness. Patient was apparently asymptomatic 10 years ago. Then she noticed protrusion of right eye, which was gradual in onset, slow progressive. She also had difficulty in lateral movement of the left eye, but no diplopia. She also has drooping of both eyelids from childhood, but no progression or diurnal variation and no fatigue observed. She sought medical consultation in between, but her symptoms did not improve. From last 1 year, she had associated mild periorbital pain, dull in character, mild severity. Past history, she is a known case of migraine on treatment, and there is history of removal of mole over right side of forehead. Personal history, non-allergic, non-vegetarian by diet. Family history, not significant. Examination was within normal limit of generalized examination, but normal head posture and no face tilt. Proceeding to the ocular examination, visual acuity, pupillary reaction, intraocular pressure was within normal limit for both the eyes. Lid adnexa examination showed brow elevation in right eye. Lid crease was absent. Margin reflex distance 1 was 2 millimeter. Margin reflex distance 2 was 5 millimeter. Levator palpebrae superior's function was 6 millimeter fair, and there was lid glad present. Bell's phenomena was normal. In left eye, pro was at normal position, lid crease present, MRD1 2 millimeter, MRD2 5 millimeter, LPS function 8 millimeter fair. Bell's phenomena was normal, lid lag absent. Further examination showed lateral rim to corneal apex distance in right eye 20 millimeter and left eye 16 millimeter. That promoted us to think of axial proptosis in right eye, no enlargement on valsalva, no resistance on retropulsion, absent orbital pulsation, absent prui. Further examination of right eye, conjunctiva was within normal limit, but cornea showed superficial punctate keratopathy. Anterior chamber was formed, lens was within normal limit, extraocular movement was within normal limit. Left eye had marked findings in extraocular movement. There was marked restricted abduction, retraction of eyeball on adduction, and narrowing of palpebral fissure. Further on, we carried out the forced duction test, which was positive, demonstrating restricted lateral rectus. Fundus examination of both eyes was within normal limit. Here in the pictures, we can see the absent lid crease. Here, retraction of eyeball on adduction in the left eye and narrowing of the palpebral fissure, and restricted abduction in left eye. Differential diagnosis: orbital pseudotumor, mucocele, meningioma, thyroid eye disease, malignant lymphoma or leukemia, Duane retraction syndrome, abducens nerve palsy. Investigations were carried out. Complete blood count was within normal limit. Erythrocyte sedimentation rate 12 millimeter in first hour. C-reactive protein 1.38 normal. Thyroid function test was within normal limit. Peripheral blood smear was normal. MRI brain with orbit was normal. On the basis of clinical findings, ocular examinations, investigations, this is likely a case of left eye Duane retraction syndrome type 1 with contralateral pseudoproptosis and bilateral mild ptosis. Discussion: Duane retraction syndrome is congenital cranial disinnervation disorder with prevalence of about 1:1 per 1,000 in general population. 90% cases are sporadic with female preponderance. Most common type of congenital aberrant ocular innervation. 80% of cases occur unilaterally with left eye predominance. Pathology is an absent or dysplastic abducens motor neurons with aberrant innervations of the lateral rectus muscle by the oculomotor nerve. Simultaneous activation of the medial and lateral rectus muscle may be the cause of global retraction. The diagnosis is primarily clinical. 76% of individuals have strabismus. There is limitation of abduction, induced ptosis on adduction, poor binocular vision. Amblyopia occurs in about 10% of individuals. And isometropia, there could be compensatory head turn to avoid diplopia. The classification by Huber classifies into duodenal retraction syndrome type 1, type 2, type 3. Type 1 has poor abduction and good adduction as most of the nerve goes to medial rectus. Type 2, there is poor adduction but good abduction as sixth nerve is intact. Type 3, there is poor adduction and poor abduction as the third nerve split is equal. Here are the pictures demonstrating DRS type 1 and type 2. So on the basis of clinical findings, ocular examination investigations, we conclude this as a case of unilateral duodenal retraction syndrome type 1 with contralateral pseudoproptosis and bilateral mild ptosis. Thank you.
Thank you, Dr. Utkarsh. Sir, any comments or questions, sir?
How do you rule out congenital extraocular muscle fibrosis here?
Okay.
Especially because there was ptosis as well.
Yes, sir. Sir, mainly, sir, the typical movement of, sir, adduction and narrowing of palpebral fissure, and there was specific only in lateral rectus muscle of left eye restriction, sir. Not the muscles.
Would imaging help if you still have any doubt?
Pardon, sir?
Would any sort of imaging help if you still have any doubt? MRI?
Yes, MRI will be helpful. Because in this we had done and it was completely normal study, and sir, we rechecked it.
So what is another common condition which is associated with pseudotosis and squint?
Pseudotosis and squint. Okay, sir. Chronic progressive external ophthalmoplegia.
But there is no pseudotosis, right?
Okay, sir.
Monocular elevation deficiency, MED.
Sorry.
Okay. Thank you, Dr. Utkarsh. May I request Dr. Amit Kumar? Dr. Amit? Please start.
Good morning, everyone. I'm going to present a case report on management of ocular adnexal injury in an animal bite. So I have no financial disclosure or conflict of interest. My patient was an 8-year-old male child, a resident of Vaishali, who presented with complaint of pain, swelling and bleeding in the right eye, following trauma to the face and right eye, following a dog bite 4 hours back presentation. The patient was apparently well. I was playing in the backyard while he was bitten by a neighbor's dog, and following which he developed immediate pain, swelling and bleeding from the periorbital regions. On examination, the systemic examinations, general systemic examinations were within normal limits. On clinical examination, on local examination, the visual acuity in the right eye was 6.9 and left eye was 6.6, and which didn't improve on pinhole. On eyelid examinations, you could see the laceration extending from the right upper lid to the medial canthus in the upper lid, and in the lower lid also it extended to the upper part of the cheek. There were periorbital ecchymosis and edema encompassing the eyelid and the surrounding skin, and there was no active bleeding at the time of examination. The remaining ocular examinations were within normal limits, and the posterior segment was also within normal limits. On imaging of the patient, the X-ray and the CT scan didn't reveal any orbital fractures or any foreign bodies or any evidence of intraocular injury. So on the basis of this history and findings, the diagnosis of ocular dog bite with right eye periorbital and conjunctival laceration was made, and the management started at the time of presentation itself, when the wound was cleaned with sterile saline and the laceration was assessed for signs of infection. The patient was started on oral amoxicillin clavulanate for preventing infection, and topical ointment also applied. The status of tetanus immunization was assessed, and the patient was immunized, and oral acetaminophen was advised for pain control. The patient was planned for surgical repair under general anesthesia. The laceration was repaired with careful alignment of the eyelid margin to margin for cosmesis and further preventing further complications. During the surgical procedure, the rabies immunoglobulin was also given at the site of the bite, as the patient was not immunized to the rabies. and also the patient was started on rabies vaccination as per the schedule of day 0, 3, 7 and 14, and the patient was advised for daily review for the first 3 days to monitor the signs of infection and proper wound healing, and then weekly for full recovery. So this is the follow-up images of the patient on the presentation and day 1, and this is the final 1 month follow-up image. The wound was healed. The wound healed on the final 1 month visit, and there was no residual pain or discomfort. However, there was ankylosing was noted in medially with minimal scarring, and the patient was planned for surgical release of ankylosing. So coming to discussion part, the incidence of animal bite in India is reported to be around 1.7%, of which 91% are dog bites, with children being a highly vulnerable group. And the dog bites lead to the ocular lesion are rare but can have serious implications, including visual impairment and significant cosmetic defects. Prompt and thorough assessment coupled with appropriate surgical repair and antibiotic therapy is critical in preventing complications. As in this case, the timely intervention resulted in a positive outcome, with the patient regaining full visual acuity and minimal scarring. So, and the key points I would like to highlight here are that in these cases, the immediate washing with normal saline or powdered iodine is a very important step, urgent step. However, not all animal bites should be have to be repaired immediately. Rabies being a fatal condition, any suspicion of rabies is indication for post-exposure prophylaxis, rabies vaccine plus minus rabies immunoglobulin at the site. Rabies immunoglobulin is given at the site of bite after test dose at 40 injection unit per kg. The rabies vaccine given is given in deltoid region and anter-aspect of thigh in young children, and not to be given in gluteal region, as it gives to weaker immune response. And also pregnancy is not a contraindication for rabies vaccination. To conclude, this is I would like to is aimed to highlight the importance of immediate and comprehensive medical evaluation and treatment of ocular dog bites to ensure best possible visual and cosmetic outcome, and also regular follow-up essential to monitor healing and managing any arising complications. Thank you.
Thank you, Dr. Amit. Any comments from Santosh or Dr. Sahib?
So suppose this case was associated with ptosis. So how will you proceed for the management of ptosis? What will you do?
Ptosis, sir, I think the first the alignment of the repair of the wound, closure of the wound will be of primary importance, sir. And after the healing, there may be residual or additional ptosis in this patient. We can manage appropriately after the healing of this wound caused by the bite.
How many days?
Sir, as in this case, after one month, sir, the wound was completely healed, and I think the scarring was complete, sir. After that, we can assess for the ptosis and manage accordingly, sir.
Ideally, you should wait for 6 months.
Thank you, sir.
Thank you, sirs. Now this is the end of free paper PG session. Before going to the keynote address, may I request Dr. Prasansa to present on topic the dripping ceiling. Dr. Prasansa, please.
Good morning, everyone. I thank Bihar Ophthalmological Society for giving me this opportunity. I am Dr. Prasansa Narnoli. I have just completed my fellowship from LV Prasad Eye Institute, and I have joined Lakshmi Netralaya. So my topic for today is Seal the Dripping Ceiling. Why this unusual title? I hope I could make understand everyone at the end of this session. So a 9-year-old male child student presented to us with the chief complaint of right eye swelling of the upper eyelid, protrusion of the eyeball associated with discharge, redness and pain since 3 weeks. My patient was apparently all right when he had a fall from bicycle while returning from the school and sustained a blunt injury to the right forehead. He consulted at nearby medical college on the same day and was admitted in the neurosurgery department. In the next 3 days, he developed a gradual swelling of the eyelid with forward protrusion of the right eyeball. The frontal craniotomy was done at the medical college to evacuate the subdural hematoma. There was a progressive swelling of the lid for which repeated aspiration was attempted at the medical college. Due to the persistent increase in the forward protrusion leading to exposure changes, the child was referred to L.V. Prasad Eye Institute for right eye evisceration. When he presented to us, it was 23 days post-trauma. Patient was conscious but uncooperative. He was affebrile. There was no neck stiffness, no vomiting. The child was not cooperative for detailed comprehensive examination. The vision was PL positive. There was a periorbital fullness with a diffuse lid edema and a cystic swelling. There was a subaxial proptosis with the inferior displacement of the globe. There was an exposure keratopathy and there was an inconsistent pulsation. Globe was tense and tender. On imaging, we saw a large defect in the roof of the orbit with the displacement of the bone fragment into the orbit was noted, and through this defect, there was an iso to hypodense brain tissue filling in the superior orbit. The similar finding was noted on T1 weighted MRI. With this, we made a diagnosis of right side orbital roof fracture with traumatic meningoencephalocele with exposure keratopathy. So, management in such cases aims at saving life, globe salvage, and saving vision. Management include multidisciplinary teamwork, which include neurosurgeon, neuroanesthetist, and the oculoplasty surgeon. Let's understand the concept of meningoencephalocele and the 5-gasket seal technique done to repair such cases with the help of schematic representation. So the first image is the image of the normal skull. Whenever there is a trauma to the craniofacial region, there can be a displaced roof fracture. Whenever this fracture is, the size is more than 2 square centimeter, due to the differential pressure, immediate or delayed, there can be a tissue herniation with the formation of CSF pouch as seen in the image 4, leading to the downward and forward displacement of the globe, as seen in our case. So how do we manage such case? First, we do a frontal craniotomy and put a ventriculoperitoneal shunt to decompress the brain tissue. As soon as the brain tissues are decompressed, the fracture site becomes more evident, as seen in the image 5. Then we place a orbital implant followed by a periosteal flap, gel form, and a layer of fibrin glue, and then finally a dura is repaired with the help of a synthetic duragen. This tightly seals the roof and prevent the further complication. Coming to our case, our patient was taken under GA. Then the coronal flap was made. The previous craniotomy wound was enlarged. The ventriculoperitoneal shunt was placed and the brain tissues were decompressed. As soon as we decompressed the brain tissue, the fracture site became more evident. All the brain tissues were retracted with the help of a retractor, and all the tissues were tethered tissues at the site of fractures were released. Then the titanium implant was placed, followed by a periosteal flap and the gel form and a layer of fibrin glue, and finally a dura was repaired with the help of a duragen, and the craniotomy wound was closed. Then we approached through a lid crease incision to the superior orbit to remove the displaced fragment of the bone. So at post-operative day 1, our patient was doing well. There was a significant reduction in the proptosis. The wound was healthy. The sutures were intact. The tarsographies was intact. There was a CSF leak from the wound which was managed conservatively. At post-operative 3 months, the vision improved from to CF 1 meter. There was a decrease in proptosis. There was a mild hypoglobus, and there was a 30-degree RXT. On corneal examination, there was a macular dense scar. We did a B scan, which was normal. We did VEP, which showed mild latency, and the patient is planned for optical penetrating keratoplasty. So to conclude my slides, cystic swelling associated with exophthalmos post-trauma, always suspect a roof fracture with meningoencephalocele. CT and MRI both plays an important role in such cases to rule out the extent of fracture and the soft tissue herniation. A multidisciplinary approach, including Oculoplasty surgeon, neuroanesthetist, neurosurgeon is required in management of roof fracture with meningoencephalosis. Thank you.
Thank you, Dr. Prasansa. Sir, any question or
I
comments?
have one question. Hello, Dr. Prasansa.
Yes.
In case of your case, there is still in post-op there is a CSF leak.
No, there is no post-op. After conservative management, it was stopped.
No, on post-op day. So that's why I just add one information is nicely done. Along with that, you can go for a fat graft from our side.
Yes, yes, yes.
We can help. Moment you can that with the help of the surgeon, neurosurgeon generally debulk it as much as. Then if it is on his part and he can go for plating titanium. In our roof, we can go for plating. Over that, we can place the
Mucosal
fat.
graft or fat.
Then along with that, we can go for other muscular graft. There should not be a two graft. It is a pedicle kind of thing. Then fat will help because otherwise it may be again on post-op date. Sometimes it may be difficult, and for infection point of view, it is one of the important. So in this, your patient, it was done in the neurosurgery OT or in oculoplasty OT?
With the neurosurgeon, we also went.
No.
It was
Yes,
multi-speciality
you-
hospital.
Yes, it should be always
The
multi-specialty.
patient
In
was
the-
ours, the patient presented to us, so we took with the neurosurgeon
Yeah,
the case.
because for 5 days ICU backup is very, very essential in
Yes,
that.
yes, sir. Thank you, sir.
Thank you, sir. May I request Jan Kumar Das, sir, for keynote address, temporalis muscle flap in excentrated socket.